This photograph of a 20-year-old female shows a horizontal scar from a penetrating trauma to her right eye. Her acuity dropped to 660. The deficit is profound because the scar sits dead center across the visual axis, physically blocking light. Standard optometry cannot help here. Spectacles simply bend light to compensate for refractive errors in an otherwise clear eye. They cannot bend light around dense structural scarring within the corneal stroma itself. Improving her vision requires bypassing optical refraction entirely. We have to directly alter the tissue architecture. Restoring the visual axis requires an invasive negotiation with the cornea's strict biomechanical and immunological limits. Those limits dictate whether we replace the tissue or reshape it or salvage it. For the dense central scar we saw in our first case, the primary indication is an optical keratoplasty. This surgical procedure removes the diseased host corneal tissue and replaces it with a clear, healthy donor cornea. This architectural replacement takes two forms. Penetrating keratoplasty excises a full-thickness block of the cornea. Lamellar keratoplasty takes a partial-thickness approach, selectively removing and replacing only specific anterior or posterior layers. Regardless of the depth, the procedure is bound by strict logistical constraints. Donor tissue must be surgically harvested within 12 to 24 hours of death. Once harvested, the tissue goes into specialized storage at an eye bank. It can be kept in hypothermic storage for up to 10 days, or placed in an organ culture medium, which maintains its viability for up to 4 weeks. Before it reaches an operating room, the donor tissue must clear absolute screening contraindications. A cornea is discarded if the donor had an unknown cause of death, central nervous system infections like encephalitis, most hematological malignancies, or systemic infections like HIV, tuberculosis, and hepatitis. If the tissue is cleared, the next barrier is the recipient's biology. The healthy human cornea enjoys immunological privilege. By maintaining a complete absence of blood vessels and lymphatics and hosting very few antigen-presenting cells, it largely avoids detection by the host immune system. But pathology destroys that privilege. Severe recipient stromal vascularization and active inflammation cause aggressive capillary networks to creep into the matrix. Once blood vessels infiltrate the area, the host immune system is sensitized. It identifies the foreign HLA antigens present in the donor cornea and mounts a targeted attack. This immunological rejection can compromise the entire graft at once, or it can systematically target isolated layers, breaking down the endothelium, the stroma, or the epithelium individually. A successful keratoplasty relies on the long-term clinical suppression of the host's innate drive to vascularize the tissue and reject those foreign HLA antigens. Now, consider eyes where the optical axis is perfectly clear, but the stromal curvature itself is flawed. These are purely refractive errors: myopia, hypermetropia, and astigmatism. Here, we transition from total tissue replacement to elective tissue reshaping. The most common intervention is LASIK. A superficial flap is created and folded back to expose the stroma. An excimer laser vaporizes tissue to a precise depth, flattening the central cornea to correct myopia, or ablating the periphery for hypermetropia. LASIK dominates refractive surgery, offering rapid visual rehabilitation, high postoperative comfort, and minimal stromal haze. But the amount of refractive error we can correct is dictated by a strict biomechanical limit. After ablation, a residual corneal base of at least 250 micrometers must remain intact. Breaching that 250 micrometer threshold causes corneal ectasia. The thin stroma simply yields to normal intraocular pressure and bulges permanently outward. For patients disqualified from LASIK due to low initial corneal thickness, we use a surface ablation technique called photorefractive keratectomy, or PRK. PRK comes with clinical trade-offs. It can only correct lower diopters, up to 6D for myopia, and because it ablates the surface directly, the epithelial healing process is slower and significantly more uncomfortable for the patient. However, because PRK does not involve creating a superficial flap, it eliminates the risk of late flap dislocation and drastically reduces the threat of ectasia. Elective refractive surgery is a strict mathematical calculation. The desired dioptric correction must never exceed the structural integrity limits of the patient's individual stromal thickness. Before any elective reshaping or rehabilitative grafting can even be considered, the ocular surface must survive acute environmental threats. Chemical injuries represent the ultimate disruptive event. Chemical trauma falls into two categories. Acid burns cause superficial damage that halts rapidly. Alkali burns are more common and dissolve rapidly, penetrating deep into the stroma. This triggers aggressive necropsis, leading to the disruption and occlusion of the limbal vasculature. Clinicians grade the severity of these burns by looking for limbal ischemia. We identify this through distinct vasoconstriction and perilimbal blanching, a stark whitening of the conjunctiva that indicates severe loss of blood supply. This ischemia starves and kills off the limbal stem cell reserves. Without these stem cells, the eye loses its ability to resurface itself, resulting in persistent epithelial defects and blinding vascularization. Managing moderate to severe chemical injuries requires an aggressive, multi-drug pharmacological protocol to stabilize the tissue. Topical steroids are deployed immediately to reduce severe inflammation and neutrophil infiltration. At the same time, systemic and topical ascorbic acid is administered to actively drive collagen synthesis and force wound healing. Citric acid is added as a powerful inhibitor of white blood cell activity, further reducing inflammation. We also use tetracyclines, which act as direct collagenase inhibitors, preventing the neutrophils from causing the stroma to ulcerate and melt. In acute chemical trauma, the clinical priority shifts entirely away from optics. The sole objective is salvaging the limbal stem cell niche, the absolute prerequisite for any future visual recovery. We had examined 3 distinct vectors of corneal intervention: replacing a scarred matrix with a donor graft, calculating precise ablation depths to correct refractive error, and chemically halting acute necrosis. Across all 3 scenarios, success is governed by the same biological imperatives. We must preserve the limbal stem cell reservoir, strictly respect the tissue's geometric thickness limits, and aggressively suppress host inflammation. The cornea's defining characteristic, its total avascular clarity, is simultaneously its greatest optical asset and its most vulnerable structural liability. Restoring sight requires the precise clinical defense of a fragile